Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Peer Service Integration, Delivering Peer Support in an Outpatient Setting. And our presenters are Rachel Fitzpatrick, Assistant Project Director at the Opioid State Response. Mary Alice Ryan, New York State OASAS Bureau of Peer Integration in CHAMP. Connie Willey, CEO of the Champlain Valley Family Center. Dennis King, Director of Peer Engagement and Recovery Services at the Champlain Valley Family Center. Keisha Graham Wilson, Project Director of the Cody Project, CN Guidance and Counseling Services. Adriana Kiko, Senior Recovery Outreach Specialist at CN Guidance and Counseling Services, and Sherry Zakharchenko of the Center for Problem Gambling. They'll be joining us in just a moment. First, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, and recovery workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation and to welcome our presenters.
Hi, my name is Mary Alice Ryan, and today we're here to talk to you about integrating peer support services in outpatient settings, and also how important they are to the treatment setting and how to integrate with the clinical services. I obviously would be negligent in not mentioning COVID and what has changed. Peer support services are still going strong during COVID. The biggest difference is that they're being delivered by telepractice instead of face-to-face. And I have to say that the peers did not miss a beat when the pandemic hit. And with the executive orders coming in every month for approval of teleservices, the peer support is being delivered, and so is the family support services. One big major thing that OASAS did with the peer support addiction services is that we made it a regulation that all outpatient services have to include peer support as a required service. So peer support is definitely, the peer they're on equal footing with the patient, the client, the participant, whatever word you would like to use, and they link the participant to formal recovery support. So they meet the person where the person is. The person might want treatment, they might want an outpatient, they might want inpatient, they might want to just go to a meeting, they might want to just have a cup of coffee, they might just need a ride to detox, or they might just need a ride to the doctor's appointment. So there's different recovery methods and there's different paths, and this is, as everybody knows, is a much different approach, traditional. This is a much different approach than we've had traditionally in the addiction field. Peer support services are person-centered, so they focus on the person, not on the treatment plan. And then Rachel will get into that later, how they're changing treatment planning to be more person-centered. And then the peer, they based on their education, and then they get work experience, but they also have their own lived experience to share with the participant, which helps the participant move forward in their journey. So, for example, how someone described it to me one time is if you're driving in the car and you have the participant is driving, the peer is just kind of putting their hand on the wheel and guiding. They're not telling them where to go, to where to turn right and where to turn left. They're just kind of giving a little nudge here and there. They definitely provide crisis support, which happens quite often, especially after periods of hospitalization or incarceration. The peers can be that essential link or that warm handoff. If you just OD'd and you're coming out of the emergency room, or you're still in the emergency room, and you have a peer there to talk to you, or just to, just to take you home, or just to ask if you want to go to treatment, makes a huge difference sometimes. And coming out of incarceration, peers have been instrumental in helping people link to a recovery center, link to any kind of recovery path. Peer support definitely is not, I mean, it's everything opposite of what I just said. It's not clinical, but what we wanted to talk today, we don't want to forget about the clinical. We want to integrate the peer support services with the clinical. The clinical is still very, very important as this peer support. It's not coercive. It's not mandated. It shouldn't be mandated. If you're not monitoring somebody, you're not doing the filing, you're not sweeping the floor, cleaning out the bathroom, you're actually working with the participant. And I just talked about a little bit about what a certified recovery peer advocate does. It's an OASAS, it's certified through the certification board under ASAP. You can find it on the website, and it tells you what the requirements are, how to get certified. And certified recovery peer advocates support individuals and families as they work towards achieving self-identified goals related to recovery, wellness, independence, and self-sufficiency. Peer support includes outreach, education, and linkage to social and other support services. So it's a profession. They're professionals. They're treated as professionals, and OASAS actually, especially down in New York City, the Peer Integration Bureau will help people, will collect resumes and help people get placed in jobs. And there's also some colleges down the city where they are training and placing people in jobs. So the outpatient programs are looking for SERPAs, and as I said, peer support services are billable if they're delivered by a SERPA, and if they are supervised by QHP. And you'll see that the telephonic 5-minute calls are now billable. That came about because of COVID. There is required documentation for billing. It includes progress notes, and Rachel will talk a little bit about that, how that fits into the treatment plan. And it's updated in the chart, and they're not doing like time periods now on the chart. You're updating as you go along. So you just have to talk about the service that's provided and how it supports one of their goals. Also Zoom calls and meetings and groups, services have been delivered that way as well.
Thank you, Mary Alice, for that. So as you heard in my introduction, I'm Rachel Fitzpatrick. I'm the Assistant Project Director on the State Opioid Response Grant. I'm excited to be here both virtually and in spirit with my wonderful colleagues, both at OASAS and with our certified programs that continue to really just prove their dedication in providing a system of care for people who can benefit from peer support and other addiction services related. For those of you who don't know me, over the last few years at OASAS, I've been lucky enough to help implement and oversee multiple projects funded through SAMHSA's opioid crisis funding, including the Centers of Treatment Innovation, or CODIs, as I'll be referring to them throughout this presentation. This has allowed me the opportunity to work really closely with folks in addiction services at a time where certified recovery peer advocates were new to the field and were being implemented across the state at a different volume. And we were really learning a lot as the SERPA workforce continued to grow and training continued to evolve. So we have a lot of lessons learned to share with the field today. And I hope we can continue to have meaningful conversations about peer support and how essential they are in their role providing true person-centered care. So up on the slide, you'll see the new outpatient regulation and treatment planning regulations. So this is our Part 822 outpatient reg. We've made some updates that are relevant to peer services. One is that it requires peer support be a service that is offered within an outpatient setting. So for those programs that did not offer peer support, it became a regulatory requirement. So peer services, as they have been growing pretty rapidly throughout the last few years, now they're a requirement. So we're really looking to solidify and just continue to grow a robust network of these amazing peers doing amazing work. A lot of it is supported through the opioid crisis funding, and we're excited to have this play out in a regulatory standpoint as well. So in treatment planning, that's a little bit different for peers. So clinicians are often working on treatment planning with individuals. Peers, because they're not in a clinical role and it's not really within their scope to have something as formal as a treatment plan that they're signing off on, they're working on self-identified goals with individuals. However, that individual who's enrolled or admitted into a Part 822 outpatient, they do have a treatment plan that's required to explicitly say that peer support services is part of their treatment plan. So this assures that the treatment plan reflects the individual's desires and goals that they want to work on and the services that they're interested in engaging in. And it also creates a space where the clinician who is supervising the peer and providing that kind of clinical support to have a record that shows that this is an integrated system of care, that peer support, although the scope is different and distinct in its own right, that it's a really essential part of someone's treatment plan, regardless of what other services may be outlined on that. Another thing that including peer services within the treatment plan does is it assures that you're able to have that documentation required for billing. So there's been some exciting billing updates in the last year or so related to peer support services, including a rate enhancement after the first 2 years of CODI, which I know the field was pushing, and we certainly saw the value in pursuing with the Medicaid adjusting the rates for that. And another thing that's important is a question that comes up often is when you're creating your documentation, which peers do on a regular basis for each engagement that they have with an individual, although it's billed in increments, you only need one progress report per engagement. Peer support should also be part of a discharge plan. If other services are provided within a detox or another level of care that's not an outpatient setting, this allows for those warm handoffs that Mary Alice was talking about and just a better transition into different levels of care, making sure that individuals are continuously supported and that we're able to provide the services when they're willing to engage during that crucial time. We have also a note here that outpatient programs do have the ability to contract with recovery providers to meet that peer services requirement, and that's done through an MOU. So that is something that is up to an agency's legal department to assure that that is set. So a little more information about the specifics of the progress note, because we get a lot of questions about this. So the progress note is written and signed off by the staff member who's providing the service, including a date and relating the note back to the individual's treatment goals that are outlined in the overarching treatment recovery plan. And another thing that you can include as a SERPA is any recommendations or determinations that are to continue or revise the goals in treatment planning. This is also a place where the clinician will include information gathered during an assessment. There's not a specific time frame for updating treatment plans, which is also new. And we did this because we're really trying to align our documentation, our regulatory requirements with that of treating a chronic health condition. So we all acknowledge that addiction is a chronic disease. However, some of our methods of documenting and treatment planning didn't necessarily line up with that, and we're consistently working towards that at OASAS to provide the best evidence-based care and regulatory oversight possible. Now we're going to start talking a little bit more in depth about the Centers of Treatment Innovation, or the COTIs. So this was a very large part of OASAS's response to the opioid crisis through the SAMHSA state opioid response funding. So essentially, COTIs were meant to be uniquely tailored, community-based, mobile responses to a high-risk population that was not presenting at our OASAS brick-and-mortar traditional settings, so outpatient, inpatient, detox, that kind of more transient, potentially actively using, really high-risk populations, such as women who are pregnant and parenting who use opioids or heroin, people who have become recently disengaged from addiction services, people who are reentering communities after periods of incarceration. We know how many barriers there are to accessing care for folks without additional barriers. So COTI was really meant to support existing outpatient program and using their in-community services authority to provide those crucial outpatient services in a mobile way. So they're connecting people who use opioids and heroin to services who have disconnected or have disengaged from services, and their main point of engagement and outreach is using peer support, and specifically certified recovery peer advocates. They were always developed under the guise of meeting people where they're at and at varied stages of contemplation, and always supporting linkages to a full continuum of care. So when we talk about high-risk populations that aren't presenting to our traditional settings, we know that it's for a reason, and we also know that initial engagement is crucial. It's something that the peers have continuously proved to be extremely savvy at. Getting people to engage who have been disengaged from treatment for a substantial amount of time, or people who are really, really maybe not so interested in talking about their use of opioids or heroin or any other drugs, but we're interested in getting other community supports. So it's the expectation that the CODI staff and peers are all savvy in navigating different referral types within the specific communities that they're working in, regardless of an individual's contemplative stage or their motivation to seek addiction services. So peer services should always be aligned with that unique individual's goals at whichever pace they feel comfortable engaging. Through CODI, every outpatient that received funding, all that they were required to do on paper was provide mobile treatment, outpatient services, peer support, rapid access to medication-assisted treatment, which we know is the first intervention in evidence-based treatment of opioid use disorder, and telepractice capability. So we're trying to overcome transportation barriers and various other barriers that might keep people from being able to successfully achieve their set path in recovery. So the way that this rolled out was very different in different areas across the state. We're very geographically diverse. We have different socioeconomical communities across the state that were funded. We really wanted the providers to be able to use the funding that was completely unique to their community's needs. So if transportation was the largest issue, a CODI would purchase a fleet of vehicles. If medication was the biggest barrier, some bought a mobile treatment van where they hired a nurse practitioner or another prescriber that was able to meet individuals on the van and provide a script where they could pick up at a local pharmacy if they weren't able to make it to another setting that provided medication. Really just trying to fill in any existing gaps as well as learn to engage with a different population. Something that I think the peers that are doing mobile outreach, oftentimes street outreach through CODI, they've become so incredibly knowledgeable about the different resources within their community. They work closely with the Department of Health Drug User Health Hubs, syringe exchange programs, other harm reduction services, linkages to other community-based programs and public assistance agencies, primary care services. The peers are really the face of CODI and the people who are often doing the work to spread the word, make sure the community knows that they're out there, that they're available, and that they're willing to help anyone who's willing to engage with them on whatever level they're comfortable with. And what we were able to do is collect additional data, so outside of the client data system, and more pre-engagement data through CODI. What you'll see on this slide is the rates of engagements of individuals that were subsequently admitted after a peer engagement into our program and how quickly they became admitted. Also just shows kind of an example of where people are engaging folks, community-based organizations, parole offices, inpatient programs, different jails and correctional facilities, social media, partnering with different emergency departments, a really vast array of collaborative efforts have been made through CODI to link individuals that need medication-assisted treatment and other addiction services.
And then, I'm sorry, it's Mary Alice, just that other table on the other side there is peer engagement specialist, which is one of the programs that was started by the Opioid Task Force. And they're like they came about before SERPAs. That's why they have that name, but their numbers are there too. And there's 21 programs across the state that have peer engagement specialists, and those are their numbers there. And their numbers, they show the same success, percentage success, where, you know, how many people they've served, how many were served in the ED within 3 hours, how many were referred to treatment. So just so you know, there's just a little bit of a difference there, but it shows the same success rate.
And when we compare, you know, clinical initial engagement with peer services, it's not a one-to-one comparison or anything like that. But what we're seeing in the data that we're able to collect is that we do have high rates of engagement when peers are making that initial effort, and even more so when they work within a multidisciplinary team, which the CODIs function in. So it's supported because you have to be supervised by a clinician, but also those are the folks that are going to be there when you call them and somebody states that they're ready, that they're interested in an assessment, that they want to talk to somebody about starting, you know, medication assisted treatment, or that are going to be able to, you know, provide that clinical support when people need it, when they're ready, and have it there, you know, in a timely manner where we're able to, you know, keep them engaged and keep them safe. So in the COVID-19 pandemic timeline, this has affected, you know, just about everything, including how services are provided in our healthcare system, as well as in addiction treatment, and as well as in peer support. It's actually allowed for more flexibility within the scope of peer support. So as of March 9th, SERPAs became authorized to provide services via telephone as well as telepractice. So those were previously only allowable if you are a qualified health professional or a QHP, as we refer to them in our setting, until the state of emergency is lifted. It's continued to be extended through executive order. And although we have an executive order in place that allows for the telephonic service delivery and telepractice, all policies and procedures must be modified in accordance with DOH and CDC safety protocols. So services that may have been provided, you know, on the street or in a community center or in a library or an outpatient setting, now may be done over the phone or on a telepractice platform, but they're also billable, which is an important thing, that we want to make sure that people are billing for the peer support that they're providing and really maximizing their revenue, because peers are such a valuable part of our system. You know, we want agencies to be able to benefit financially and have that contribute to their sustainability as a program, to make sure that peers continue to grow and become an even more integrated part of addiction services. I'm excited to pass it off to a CODI director herself. Right here on the screen, you'll see an example of a CODI mobile treatment van. Without further ado, I will pass it off to Keisha.
Hello, everyone. My name is Keisha Graham Wilson. I am the project director for CN Guidance CODI Mobile Recovery Unit. This is an example of our RV that we drive around the community of Nassau County, New York, in Long Island. I have a mobile recovery unit team that goes out on this RV On this RV, we have 3 treatment rooms. And we have telehealth equipment that we were utilizing long before the pandemic. My team consists of peers, case manager, clinicians, an RN, and a prescriber that we work with. And like Rachel mentioned before regarding the Cody teams, we really go out in the community and work with individuals who may have a barrier of getting to a traditional clinic. So our goal is to go out and provide peer services and clinical treatment services to individuals who are out in the community. They can come onto the RV and have their services on the RV, or we can meet them in the community somewhere and provide treatment in their homes or in the community. We also have 2 minivans in addition to this RV, where we're able to pick up individuals and either drive them to the RV or meet them in the community somewhere, because we are not able to transport participants on the RV. We're only able to transport staff on the RV. So I would like to focus today on the importance of peers on our team. The peers that work with my mobile team have truly been priceless. They are actually the first line of engagement when working with any individuals that we work with. So if a referral is made, we have someone that, of course, takes all the referral information, the demographics information, but we refer that person, we connect that person first with a peer. And a peer takes, takes the time to talk to that individual and find out what's going on and what pathway of recovery that person may want. That participant may not be ready for treatment. So we are also able to have peer pre-enrollment services. So that person can talk with a peer for a significant amount of time until maybe they are ready for treatment, and then they can move forward and meet with the whole treatment team. So we have been able to engage so many individuals and really meet them where they are. We can refer them to recovery centers. We can just support them in terms of maybe if they're ready to go to detox or inpatient. I've had peers help individuals to secure detox and then drive them to detox. We've had peers help individuals in terms of connecting them to different meetings in the community. We've had peers and the rest of our team provide Narcan trainings to participants and their family members. So really, the peers have been really priceless in terms of that connectivity to working with people in the community. So one of the things that we also like to focus on in terms of the peers that we work with on our team is we really keep them engaged with the whole team. They are part of our case conferences. They are an intricate part of our whole treatment team. There is no separation. They are truly part of the entire team. They share feedback. They add their information. And it's important that they feel part of the team, and that everybody understands their role, the peer role as part of the team. One of the important things that we also pay attention to at Central Nassau Guidance is we make sure that we focus on the self-care of peers. I know that I'm sure Adriana is also part of this team today, and she will also talk about that. But we make sure that we pay attention to self-care and making sure that peers are paying attention to their self-care and taking time for that so that they can make sure that they are healthy and being able to be present for the participants that they may be working with. So we really value the peers that we focus on. Supervision is also something that is very important. We make sure that we provide weekly supervision, that we are available to the peers and all of the staff, um, that they can call us whenever they need to, um, outside of the scheduled supervision, just to, have contact and communication with any of the supervisors to make sure that they know that we're available to them. We also have a program at Central National Guidance where we have peers working with the EDs, some of the Northwell EDs. They contact peers and we follow individuals every 30, we start with the 7-day. Actually, we start with the data they call us, and then we follow them every 7-day, 30-day, 60-day, 90-day, and 120 days. And that has really been also unbelievable in terms of providing support to individuals that come through the ED. That peer support has been really some of the feedback that I've gotten regarding the peer support that CNG provides to participants has been, they are so thankful that peers are able to be part of our team, that they're able to share some of their lived experience, that they're able to call someone and someone can help guide them, someone can be there to help talk to them and just be there to listen, be there to point them and help guide them in terms of maybe if they have questions about maybe their own recovery, questions about maybe where they can go to meetings. And, with this whole pandemic, this kind of shifted on how we provide services. So we really, with the RV, we were meeting individuals in the community, we were meeting individuals on the RV, and we were providing telehealth with the prescriber. So anywhere the RV was, they were able to meet with the prescriber through telehealth, and they were able to get their medication management, whether it be, medication assisted treatment or other medications that the participant was on. um, but now, since the pandemic, we're not in the community as much. We're primarily providing telehealth services to everyone. And the peers are also, like Rachel mentioned, the peers are able to provide telehealth services, which has really been fabulous that they have opened that guideline to the peers. So we are primarily providing telehealth services right now. The peers, the clinicians, we're all providing telehealth. We're doing virtual Narcan trainings, but the peer services, we've been able to open it up and really check in on individuals to see how they're doing during this pandemic. And that has been really important because there's so many people that feel isolated right now during the pandemic. So we have really increase the amount of peer services that we're providing right now, due to the pandemic. We have our peers checking in on a different clientele that maybe we didn't have them reaching out to before, but due to the pandemic, we have really increased our peer services just because people are feeling so isolated right now. So the telehealth really has been able to have us reach more individuals by just picking up the phone and checking in on individuals and seeing how they're doing. So that has been something that we really have benefited from, being able to have those telehealth and telephonic peer services um, you know, to be able to just make those calls and those touches and those contacts with individuals. Um, so I think I'm going to hand it off to Adriana now so that she can share some of her experiences as a peer with Central Nassau Guidance.
Okay, hello everybody. So my name is Adriana Kiko. I am the Senior Recovery Outreach Specialist at Central Nassau Guidance, which just means I'm a person in long-term recovery. I guess I'll just touch up on self-care and wellness a little bit, because I think it's really important for us to take care of ourselves. And I think like our agency and our supervisors just want to make sure that we're okay. So at CNG, self-care is extremely valued. And just because I'm not a client today doesn't mean that my recovery stops, right? So, and I think when we're doing well and when we're healthy, that's when we can best help our clients. So I'm just going to talk about some examples that our agency offers to the peers. So every month we meet with the COO on a Tuesday, and we just kind of check in and talk about what's going on with us. And she just wants to make sure that we're okay. We used to meet in person, now it's virtual, but she used to even get us bacon and eggs and coffee. And I think that's just amazing that, you know, the COO of the agency takes some time out of her busy schedule just to meet with the peers and make sure that we're okay. I think that speaks volume itself. And then every other Monday, we have a peer support group. It's just for the peers. A clinician meets with us just to make sure that everybody's okay. And we kind of just support and encourage one another. We also have wellness groups like meditation, yoga, cooking, coffee breaks. There's awesome boards like a shout out board. And of course, supervision is extremely important. And I think it's so important to be able to just call your supervisor if something's going on, or if I'm having an off day, or if I'm, you know, something's going on with me. I'm able to call my supervisor and say, this is what's going on, right? And she'll encourage me and she'll say, you know, take a day to yourself or take a mental health day. Um, so my experience as a peer has just been amazing. And it's been super vital to my own recovery, because I feel like just as much as I help the clients, I feel they help me just as much. And what I try to remember is that there's just so many different pathways to recovery, and everyone has their own process, right? So I always try to remember to meet the person where they're at. And what I love about being a peer is like the freedom we get to just be ourselves, right? Like I get to be 100% authentically myself. I don't have to lie about anything. I don't have to cover anything. This is where I've been. This is where I'm at. And I get to share my lived personal experiences. And I think that just gives people a sense of hope that they could do it too. And recovery is possible, right? I think when they hear on the other side me saying, me too, I get it, like I get you, I understand, you know, you're not alone. I think that just, you know, gives them hope and a sense of encouragement, right? And something else we're able to do, like we're able to do so many things, it's amazing. Like we could go to DSS with our clients, right? Help them with paperwork or insurance, take them to detox or rehab. We had a few clients we took to detox and rehab. They completed, you know, they stay the 30 days, whatever it was. And then we went back and picked them back up. And they're just amazed that we're able to do that. And they're so grateful. We're able to go to meetings with our clients like AA, NA, any doctor appointments. We're able to pick up their medications. I had a client once that had MATs prescribed. He didn't have a ride. So I went in our little minivan. I picked it up. I dropped it off to him. You know, he was so grateful. And we're able to go to even court with them. I was just thinking before how I wish I had somebody like a peer when I was going through my journey and my process, because I felt so alone. And I thought, you know, my life is over. I have all these charges and all these things going on, right? So I kind of wish that I had somebody. So it's amazing that we're able to do that today. Um, And I think us being able to do these things with our clients or for them, I think it shows them that, wow, somebody actually cares. Somebody's taking the time out of their day to talk to me, to see how I'm doing. And I think just maybe even for that day, it will give them hope and make them not give up. And we're able to build that trust and that bond with them where, maybe they're not able to share with others, but because they know that we've been in their shoes and there's still no judgment, um, I think it's a different bond. Um, and I'm just going to share a little quick story. So I took a client once to rehab, and after a few days, he called me and he just kind of wanted to leave. He wasn't really feeling it. And so I told my supervisor the story. I said, I want to go up there. I want to talk to him. So she gave me the okay. I went up there and I spoke to him. And he broke down and he like opened up to me and he ended up staying. Like he completed treatment because I was able to go there and just talk to him one-on-one. And then another client we had, this client was blind and he didn't have any food at his house. So I went to the food pantry and I made sure that this man wasn't gonna, not have food for the day. And they wanted to see him. They wanted to see him first, make sure it's for the right person. And I said, he can't come because of all, he's blind. He's not allowed to. So I made sure I went to get copies. I made copies of his ID, and I made sure I got it done, no matter how I had to get it done. And that's the awesome thing about peers is that we're able to do so many things. So I just love being a peer, and it's just amazing. So I think I'm done. I'm going to pass it off to the next person. Thank you.
I want to take a moment just to thank OASAS for today's opportunity to educate and inform our audience about the value of peer engagement services. Truly, I view peer engagement services as a bridge to help people and or their families engage in their own unique path to recovery. As stated, my name is Connie Willie, and I'm the CEO of Champlain Valley Family Center. The Family Center is a private, not-for-profit, community-based provider that is located in Plattsburgh, New York. The agency is licensed by OASAS to provide prevention services, outpatient clinic services, residential stabilization, and rehabilitation services. In addition, the agency operates a recovery center named All Ways to Recovery and a peer engagement services program, and has a designated peer to support clients in the outpatient clinic. I am in sustained recovery from substance use disorder since 1985 and have worked in this field my entire professional career. I have been and continue to be a huge fan of peer services. In 2012, I wrote a grant for homeless housing and included in the grant and in the budget peer specialists. The agency was awarded the grant in 2013, and in 2013, CVFC hired 2 peers for the very first time at this agency. I had the opportunity to work closely with the 2 peers, and their names are Dennis and Tom. And I watched the unique services they delivered assist so many individuals in heading toward their own recovery process. As the peer program grew at this agency, I saw the ways that peers were supporting recovery efforts and more specifically, actively addressing social determinants of health, namely safe housing, accessing benefits that individuals had either given up on or needed assistance in following through with, providing ongoing support, helping so many individuals to access a primary care physician or a specialist as needed, and in assisting so many people and their family members to access SUD treatment and or mental health services. A couple of minutes ago, I mentioned the first 2 peers I hired in 2013, Dennis and Tom. Both continue to work full-time at this agency. Today, I am so pleased to introduce to you Dennis King. Dennis is now the Director of Peer Engagement and Recovery Services available through this agency. And at this point, here's Dennis King.
Hello, everyone. My name is Dennis King, and I am Sustained Recovery. I haven't had a drink or a drug since May 7th, 2011. I am currently the Director of Peer Engagement and Recovery Services for Champlain Valley Family Center in Plattsburgh, New York. When Peer Engagement Services began, we had a slow start. We did in-services at the local hospital, all 3 substance use disorder providers in our county, Clinton County Department of Social Services, New York State Department of Community Supervision, and Clinton County Department of Probation. But peer engagement still didn't seem to be catching on. What we needed was one great success story to share and show how effective peer can be. This finally happened with the participants I'm going to speak about now. Peer engagement received a call from the mental health unit at Champlain Valley Physicians Hospital regarding a client they had in their unit. Peer engagement went to the mental health unit to meet with this individual. When we met with him, he shared with us what led him to be admitted into the unit. After some discussion, the plan was for him to have recovery support from peer engagement, attend outpatient at Champlain Valley Family Center, and reside in emergency housing upon discharge. He was discharged from the unit and was following all the discharge plans as in his paperwork. Peer engagement supported and transported him to all his necessary appointments. Unfortunately, this gentleman was not ready to remain sober and relapsed numerous times. During those relapses, he would end up in the emergency department. Peer engagement would come visit and continue to support him. He disengaged in treatment, but still remained in contact with peer engagement. Eventually, he ended up back in the mental health unit. This time, the discharge plan was for inpatient, followed by a referral to the Medicaid Redesign Team Permanent Supportive Housing Program through Champlain Valley Family Center. 2 days before his bed date, he left the mental health unit against medical advice. However, he remained in contact with peer engagement once again. At this time, due to not going to inpatient, he was sanctioned by Department of Social Services and could not receive assistance until completing an inpatient stay. He was officially homeless at this point, but still remained in contact with peer engagement. He once again ended up in the emergency department and remained there for 8 days as they had nowhere to discharge him to. While in the emergency department, he exhibited some drug-seeking behaviors that portrayed him to having severe mental health issues. Peer engagement visited him 3 to 4 times a day, keeping his spirits up and making him feel comfortable. Eventually, he was medically admitted into the hospital due to a staph infection. While he was in the hospital, peer engagement continued supporting him. This was noticed by the entire staff, and someone finally asked us who we were. This was a big break for the peer movement in our area. We were approached by the director of behavioral health and asked if we could meet with her to discuss a discharge plan. We happily agreed. The plan was for him to go to inpatient and then to follow the treatment recommendations from that facility. What happened next was that no inpatient would take him due to his severe mental health issues. Even though he did not have them, there were drug-seeking behaviors. Peer engagement fought hard and made referrals to every place we could think of. After numerous refusals, the chief of psychiatry asked for a meeting with the team of doctors working on his case. Peer engagement was invited to this table. There we were sitting with the shot callers of the hospital, and they were asking for our input. I would have to tell you that this put me at awe. Finally, success on our part, and he was accepted into an inpatient facility. He completed his 28-day stay, returned to Plattsburgh, and began to attend outpatient at Champlain Valley Family Center. Peer engagement was there for him upon return and continued to support him. This all began in May of 2018, and he was admitted into inpatient in late August. Today, this participant is still sober. He is on medicaid-assisted treatment. He is in continuing care at Champlain Valley Family Center, started his own construction company, has a home, reunited with his girlfriend and son after 5 years, has a primary care physician, a dentist, a bank account, and a vehicle of his own. It's been over 2 years, and he still calls me every Sunday to let me know how he's doing. He has stated on numerous occasions that if it wasn't for the support, dedication, and the hope that peer engagement instilled in him, he believes that he would not be here with us today. Another case I'm going to talk about involved a 68-year-old gentleman with a diagnosis of alcohol use disorder severe who was facing a DWI charge. He lived out in the rural area and his wife recently left him after 40 years of marriage. We were able to connect him to and provide transportation for him to outpatient treatment. He was having difficulty staying at his family home due to the memories attached and decided to move in with his daughter and son-in-law. We assisted him with health insurance issues as well as food insecurities. Unfortunately, his living situation fell apart after 2 weeks when his daughter left her husband and moved out. His family home was being foreclosed on and he could not return there. He was on a fixed income of Social Security and needed a place to live out of the rural area within his financial means and in the city closer to the stores, outpatient, and all the necessary resources. We were able to get him into an affordable senior living apartment complex located in the heart of the city of Plattsburgh. That was in July of 2018. Since then, he has completed outpatient and is still sober today. He still remains in touch with peer engagement via monthly check-ins. Since then, peer engagement has been widely accepted into continuum of care. Peer engagement has developed strong relationships at all the behavioral health providers in our area, as well as our local resource organizations. In 2019, peer engagement provided support services to 476 unique individuals in Clinton County. Now I'm going to pass it on to our next presenter. Thank you.
Hello, my name is Sherry Zakarchenko, and I'm a recovery coach at the Center for Problem Gambling in Albany, New York. I'm a person in long-term recovery from gambling disorder, which means I haven't placed a bet in 11 plus years. Our outpatient program is the only gambling disorder specific program in New York State. It's been around since 1996. There are other gambling programs included within other substance use disorder programs. So there are other ones around. Since the COVID-19 epidemic, we've been continuing with all of our services via Zoom, and that's working out quite well, although our clients are eagerly awaiting when we can be back to live services. I'd like to talk about recovery coach competencies. Personally, I believe in being well-rounded, so I attend Gamblers Anonymous, as well as Refuge Recovery, which is based on Buddhist teachings. I'm a smart recovery facilitator, which is based on cognitive behavioral therapy, and I attend other 12-step programs. And I keep up with continuing education and conferences. In my role as a recovery coach at the Center for Problem Gambling, I encourage a science-based understanding of addiction and recovery. At the center, we really emphasize that gambling disorder is a brain disorder. And we even have regular educational presentations given by an expert on the brain science of gambling addiction. And the clients really appreciate that. They get a lot out of it. We also stress that recovery strategies we use are evidence-based, and that's where I come in. I share my personal experiences of strategies that work for me. My boss often says in group that our suggestions don't come from a textbook, but from the people who found recovery. And when clients show up for the first time, many of them have never sought recovery before, and they're really hesitant to talk. It's a big problem. They're often really confused. So when I share like my triggers, my urges, my thoughts, my story, the clients can often identify, and then they feel encouraged to share their own. And then we can educate and suggest recovery solutions. Recovery coaches help with money management. In gambling disorder, it's a really big problem. So I share tried and true approaches to money management, like limited access to funds, also accountability to someone that they trust. And if needed, I help with budget planning and debt management. Also being a good sounding board, as you know, with peers, an experienced peer who really listens non-judgmentally can help the clients feel more comfortable or positive about recovery. You know, they often need a lot of encouragement to. I'd like to talk about my program responsibilities as recovery coach. At the Center for Problem Gambling, the recovery coaches, and we have two, are really immersed in the program on site most of the time, but occasionally we do accompany clients off site, such as going with them to court, probation, social services, or going with them to GA meetings. One of the responsibilities I undertake is to participate in group counseling sessions. My role is to provide that lived recovery experience that peers have around the issues that we discuss in group. I facilitate a meditation group twice a month to help with relaxation and focus. So I bring, we also talk a lot about wellness and how to incorporate that into your recovery program. The other coach, Jeff, runs a mutual aid education group twice a month to help encourage people to go outside the program and to learn more about it. Another responsibility is the development and facilitation of the program-wide recovery functions. This might be a bit unique. My role is to organize recovery-based social activities like speaker jams, gamble-free anniversary celebrations. We have cookouts, bowling excursions, other social events. And the clients really appreciate that. Gamblers are often really bored, really have free time that they don't know what to do with, so that helps. And it's been difficult with the pandemic, so we're doing a Zoom speaker jam in March. And if anyone wants information on that, it's open to the public. Anybody could join in if you want to learn a little bit more about what we do. Okay, another thing that the coaches help with is the clients have developed a private WhatsApp community thread, and that really gives them a sense of community and keeps them engaged in the program. And so we monitor that, and it's been great because we can put all of our Zoom information, when the meetings are, what's going on, and anything that they need to know about, we can put on the thread. So that's something that's really helped a lot. Another responsibility is pre-admission support. We often get clients come in who are really distraught and confused. And so my role is to meet with them, usually with the intake, so that I can provide extra information and encouragement, really help reduce those anxieties. You know, I talk about how much the program really helped me, how great it is, you know, that whole attraction, not promotion, you know. And it's kind of important because often, you know, it's after that intake that we can make or break whether somebody sticks around. And sometimes we even go out in the field at GA meetings and, you know, give people information if they want to come to the center. And sometimes they'll do that as well. Community intervention, that involves meeting with the clients who are in crisis, need extra support. We're always available on the phone or in person. In-program recovery support is important. We're always there before and after meetings, you know, or if they need any extra help, they can call us anytime or in person. We try to give extra attention to newcomers. Participation in case conference. My role is to share insights on the clients based on my interactions with them. My boss stresses that it's really important for the recovery coaches to be included as part of the team. And because of that, I've learned a lot from the other staff members and about the process. It's been useful. One thing not on the list is gambling disorder trainings. I did want to mention that because as coaches, we'd helped out with that. And they often said that the best part of the training was having the coaches there to show what it really sounds like, what it's really like to be a person in recovery from gambling disorder, what it's like when you first get there, what a lot of the symptoms are, if you will. So I did want to give a shout out to the substance use treatment facilities and the mental health and social service programs that might be listening to this, how important screening for gambling disorder is. I just want to reiterate that I think it's really important because co-occurring addictions like gambling disorder are common and they keep the addiction pathways open. Gambling disorder has the highest suicide rate. It's 6 times that of substance use disorder. And problem gamblers, and I've seen all this, they can lose their families, finances, of course. There's always finance loss, jobs, their freedom. Many have been incarcerated, and their lives, of course. Substance use programs, I just learned this recently, receive 336 times the amount of money that gambling disorder does. And this is partially, just partially, because people don't get diagnosed and referred for treatment. There's also very pervasive downplaying in society. It's not talked about a lot. It's promoted, you know, in the media. There's state-sponsored gambling. So I believe that advocacy for gambling disorder is important, and that's something that I also like to participate in. I want to thank everyone for listening, and I hope you get something out of this. And I'm always available if anybody wants to ask me any questions, learn more about recovery coaching and gambling, or the Center for Problem Gambling. Thank you very much.
Okay, so what I wanted to mention, a couple things I wanted to mention before we had a discussion is that we have there's several resources out there on peer integration. There's a couple websites that you can go to. OASAS is one of those websites, and I do have the URL on the slides, but if you don't have access to the slides, you would go to the OASAS website, you go to the providers section, you scroll all the way down to the bottom, and you'll see peer integration. We have a readiness tool where we ask you a lot of questions, and we've had a lot of providers fill this tool out, and then we help them integrate peers into their programs. CNG and Champlain Valley are two of those programs that we have done that with. The Peer Integration Bureau, like I said, used to go out on the road. Now, we're doing everything by teleservices. Also on that page is peer guidance from OASAS, 822 program services and community clinical and billing guidance. Continuing care, which it's not new anymore, but it was new a year or two ago, where you can keep continuing to treat the person for as long as they need it. Pre-admission, which peer services are used quite frequently. So you can go talk to the guy under the bridge and you can bill for that. And then we added OASAS telepractice attestations and standards. So basically, if you are doing telepractice, you just have to fill out a form and submit it to the Integration Bureau. Also, too, I wanted to mention, it's not on the slide, another good website is the New York Certification Board, and they have all the information there on how to become a certified recovery peer advocate. And Ruth Riddick runs that. I know a lot of people are familiar with that name, especially in the city. And like I said, in order to become certified recovery peer advocate, you have to have 2 years of working experience, but you can be a CERPA-P during that time, and they can still bill for services while you are in your CERPA-P. And then you have to have a high school diploma, and you have to have a certain I don't have it in front of me, 26 hours worth of supervision, and then you have to sit down and take an exam. And then that's how you become a certified recovery peer advocate. And there's an 80% pass rate on the exam, so that's very encouraging. And as I mentioned, Queensborough College in the city, and we're trying to get some colleges upstate to run some classes and to help with taking the exam, and to also help the peers with the soft skills as when they're working at an organization. I think Adriana and Keisha were talking about it a lot. There's soft skills as well, and that's where your supervision comes in. So we go to the next slide. It's on supervision. This is real important. This is also on that website, on the OASAS website. The Appendix 3, page 31, the peer supervision competencies, very, very important. And you really heard Adriana talk about this a lot. And I loved how she talked about how they met, I don't know if it was every week or every month, and the wellness and to make sure you're doing okay. Your supervisor, you should be able to call your supervisor at any moment, at any time, and be able to bounce things off of them. Like you could be caught in a situation that you need to talk to somebody. So, and also who's supervising your supervisor. So that's important too. So we're really pushing this. It's really important. And especially if the supervisor is a QHP, they need to take the peer supervision training. It's not required, but it's definitely highly recommended. It's a different kind of supervision. It's not the same as a clinical supervision. Keisha can speak to that, I'm sure. And we just wanted to stress that before we went into any kind of discussion. And I think Rachel was going to run this part of the presentation.
So this is
Rachel?
really meant to be an open discussion amongst the peers. We have a couple questions up on the slides that we found were relevant and valuable to learning more and understanding how peers are integrated. I'll just throw it out to the group. What makes the difference related to supervision? What makes the difference between a good supervisor and a great one? As a peer, what are the most important things that you need from a supervisor to feel, one, that you're being supported in your role, and two, that you're able to help the individuals you're working with to the best of your ability? And anyone can answer, feel free to chime in.
I think it's about just making sure you're comfortable with your supervisor. I think that's really important. And just being able to be honest and upfront and open with your supervisor makes a huge difference. So I think that connection is really key. And like I said before, I'm always able to call my supervisor when, if I have any questions or I'm not sure, what should I do with this client? I'm not really sure. And I could always bounce back and call my supervisor. I think the comfortability and just the connection is really important.
Does anyone want to share an example of a peer support service or a specific goal that you've worked towards with an individual that they've successfully achieved?
Rachel, this is Dennis King. I was on mute when I was talking. I didn't realize it. So I'm going to touch on the supervisor part. I think it's important for, the supervisor to be accessible, approachable, to have good listening skills, and offer support, and to focus on self-care with the peers.
I could talk a little bit about the goals. I had one client, of course, besides, taking care of first the substance use disorder and mental health. I had a client that, lost contact with all her family pretty much. So we kind of made sure she, was able to get her family back and reunited with her family. And today she actually lives with her sister. She's having holidays with them. Everybody's super proud of her. Nobody wanted anything to do with her. And, it's a process and, it didn't happen overnight. And today she's healthy, she goes to the doctor, the dentist, and again, she's able to have her family back in her life. And I think that's, amazing. That's one of the biggest goals I think I've seen with this particular client. Besides, of course, her staying clean and sober, which is amazing.
I think this is Dennis again. I think that it's important that, we focus on there's 4 words that I like to talk about, and that's, community, connection, purpose, and then the word continue. And I think that we got to, connect them to a community of like-minded people. And, and it's one thing to get sober, but if you're just sober, you're not doing anything. And then to find a purpose for them. And after we get those 3 things, it's that word continue. And, as long as we keep continuing doing what we're doing, our life is going to get better one day at a time. And I think that's something that the peer engagement specialist can, enhance in the peers that they service.
Hi, this is Sherry. I'll just give a brief example. We had a client who was facing incarceration, and she had a goal to not gamble before that happened, and then to not gamble during, and then not gamble when she gets out. So I encouraged a lot of going to all the groups, and really I helped her stick to all of her goals while she was there, and just really encouraged her that, that she can get through it. Everything's gonna be all right, because she was suicidal. So with it, like a group effort, she managed to get through a whole year without gambling, without committing suicide, and get a pretty solid recovery. And then she was in prison, and the two coaches and I would organize trips, go visit her and write to her and things like that. We visited her several times. And then when she got out, she was just so grateful for the center that she got through it, and not gambling, and feeling more positive about life. And now she's doing really well. She's in our continuing care program. She still keeps connected to the program, and she's really one of our great success stories. And we've gotten close. So I just wanted to mention that gambling can be very serious addiction, and people really need a lot of support sometimes, all the time. Thanks.
Thanks for really highlighting how peer support can be a collaborative service with folks that have criminal justice involvement. I think this is really important to talk about because of the different considerations and nuances between addiction treatment on the full continuum of care and the criminal justice world. Would anyone be willing to talk about how, within your peer role, how you're able to advocate and help people that have either current criminal justice involvement or current court proceedings, how you're able to advocate with them in a way that is not hierarchical, and how it's not like aligned with any kind of probation-like role, that you're able to advocate for them in that setting without sacrificing the integrity of peer support and that peer-to-peer connection.
I think for me personally, I'm able to say I've been arrested, I've been in jail. It's okay. It's not the end of the world. And there is a better way. And I'm able to share with them, I did drug court, and if you complete, whatever you're asked to do, your charges get dropped. And some people don't know this, so even just me educating them just brings them a sense of relief, even. Because they feel like their life is over. I did when I did it, and when I got arrested, and I felt like my life is over. What did I even go to school for? And then my charges were able to get dropped completely. And just from them, I think hearing that makes a huge difference. And even just going with them to court, I've gone to court with the client, and they just feel like, they're not alone, and there's somebody there that cares. So that's for me.
One last question I want to throw out to the group for the supervisors on today's presentation. Do you have something you'd like to share related to different peers and their unique shared experience, their different skill sets, like within any kind of professional role, and how not every peer is going to be successful and thrive and able to maintain their self-care and wellness in every setting that we provide addiction treatment? And Cody peers that are doing street outreach aren't necessarily the same as a peer that's working within inpatient setting, a detox setting, a brick and mortar outpatient clinic. Would anyone be willing to share their thoughts on that?
Hi, this is Keisha. I think for me, I think the important thing is to provide as much support to the peer as possible, whether they are on an outreach team or in an inpatient program or outpatient program. I think it's important to make sure that they're, of course, doing their job well, that you as the supervisor are providing supervision and paying attention to all of those peer supervision competencies. I think it's important to recognize if maybe this is not going well. You need to be honest with the peer and maybe, if possible, find a better fit in the agency. But it's important to make sure that the peer is healthy and setting aside some self-care. And if you notice that it's not working out and there are some conflicts or there are some issues, it has to be addressed because ultimately the person's health is much more important than anything else. So you just want to make sure that they're okay and that they're healthy, that they are taking care of themselves. And, you know, one of the most important things for peers is you want to make sure that they're doing what they need to do so that they're not going to possibly relapse themselves. And I know that, you know, that's something that you have to face as a supervisor. You have to think about that and you have to make sure that you are paying attention to your staff and providing as much support to your staff as you can. And that's where I think the self-care is huge. Like Adriana mentioned before, I'm constantly checking in with my staff, providing support, making sure they're taking care of themselves if they need a day off, and providing a safe space for them to come to me and, you know, let me know what's going on with their participants that they're working with and what's going on with them, you know, and if I ever have to assist them with getting help for themselves, then that's what I need to do as well. So that would be my answer to that question, Rachel. I don't know about other supervisors on the call here, but that would be my answer.
One of the things that Champlain Valley Family Center has done is to partner with a local agency called NAMI CV. And that also has plenty of peers on their staff. And in talking with the director of NAMI CV and Dennis King, we decided that it would be a great opportunity to pull our peers together on a monthly basis to offer education to all of the peers and at the same time be able to have a check-in for wellness. Our peers do work together on occasion and obviously get along very well. So we're looking forward to initiating this in January of 2021. Again, just really with a focus on both education, integration with both mental health kind of areas and with substance use, work together when we can, but provide support and education to each other.
Okay. Thank you, Keisha and Connie. We're coming up on 4 o'clock, but I do want to give you guys the opportunity for anything you want to add that you'd like to be included, anything that maybe you think you missed in your portion of the presentation. I appreciate you all so much for making time again to participate. We got such, good feedback
There's
on the
one thing I forgot to
introduction, so.
there's one thing I forgot to say, Rachel. It's Mary Alice. I'm sorry, everybody. But going back to the websites, I forgot to mention For New York, another great website, and that's where all the trainings are. So as a SERPA, you have to do a certain amount of trainings each year, and then you also have to do a certain amount of trainings in the beginning, and they have, and that's where all the peer supervision trainings are as well. So if you're a QHP and you're looking for peer supervision training, so that's one site where there's also trainings all over the state, but that's your main site. And it's, if you just put For New York into Google, you'll find it, and the same with the New York Certification Board. But I think that's everything I wanted to cover. And I want to thank everybody on the call, and it's a pleasure working with everybody. I definitely, and I'm in long-term recovery myself, and it's a pleasure. And the whole piece about Keisha, the whole piece about the self-care and the wellness, and Adriana, it's so critical. Especially now. So I just want to say thank you to everybody on the call and for doing the presentation. Okay, so this slide just has our emails if anyone wants to reach out.
I want to thank all of our presenters for today's program. I hope you will all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we are meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation. Once again, thank you for joining us and keep up the good work.